So let's start with Dr. Rishi Swaroop. We all know he is director of Swaroop Eye Center in Hyderabad, a prolific cataract and refractive and corneal surgeon, and a great friend and a great surgeon, Dr. Rishi. And to discuss with him, I'll invite Dr. Anaga Heru and Dr. S.J. Sai Kumar sir to please remain unmuted, and then you can stop wherever you want and discuss about the case. Rishi, all yours.
Thank you. Is my video screen visible?
Yes, we can see that.
Perfect. Thank you so much, Harshul, for inviting me to be part of this session. Yet again, it's always a pleasure to be in your sessions and to see such lovely videos. So as you can see, this particular case is a patient who had a traumatic cataract, and you can see 4 to 5 clock hours of dislocation, subluxation of the lens at the infranasal area. All right. So we are using a cohesive viscoelastic in the anterior chamber to keep the anterior chamber formed. And I'm just trying to do a small rhexis using a intraocular forceps. And then I'll just try and spiral that out to make it of appropriate size. Now, these kind of cases, there's always a concern that there will be pre-existing vitreous. I checked for that. Luckily, there was none. And because the clock hours are almost 5, sometimes a CTR may not be enough. So we kept a CT segment on standby, just in case we had to use that. So as you can see, I've gone around the initial small rhexis and made it slightly larger. In the interest of keeping the video short, I've not shown every step. Okay, so I just made inferior paracentesis and I'm putting the capsular hooks. These are from Care Group. No financial interest of any sort. So I thought 2 capsular hooks should be adequate. I put them about 2-3 clock hours apart, and I was trying to do the nuclear maneuvers, trying to crack, but I was noticing that the capsular bag was a little too mobile for my comfort, and the lens was not rotating without moving the bag. So I thought that we need to put one more capsular hook in place. So at this point, because it was not turning freely, I decided to make one more paracentesis nasally. Is the video coming in a jerky way or it's coming smooth?
Yeah, it's okay.
Yeah, okay.
There's a slight lag though.
Yeah.
All Zoom videos are having a slight lag.
Yeah.
All right. So as you can see, we put one more hook there. And that seemed to have provided a good amount of support. And then phacoemulsification could proceed in a kind of a predictable fashion. So one has to be careful to keep the parameters low. Otherwise, if you have a little bit of surge, etc., then you might, because the bag support is not adequate, the PC might kind of jump forward or the bag might prolapse. And at times when you're doing any of the maneuvers with hooks in place, whether it's be it iris hooks or capsule hooks, you have to keep an eye on the hooks. Sometimes they tend to slip out, they tend to become loose, and that can compromise the purpose for which you put the hooks. So basically taken out the nucleus, and just whatever loose epinucleus and cortex was there in the center, we've removed it. And this is
Rishi, can you just pause the video, Rishi, for a minute?
Yes.
So, Rishi, I'd like to know 2 things so far. Like first, if you see a zonal dialysis of 5 clock hours, is it a good idea to stain with the triamcinolone before we start to check whether vitreous prolapse is already there or not?
Yes, it's a very good
secondly,
idea. But
if someone doesn't have capsular hooks, can they use iris hooks also to support the capsule? So 2 questions for you.
So answers for both your questions are yes. So one can certainly use triamcinolone. What I used in this case was an endoilluminator. I didn't show it because I had to make the video short. And with the endoilluminator, you can see very well if there's any vitreous in the anterior chamber. So I checked for that and there was none. And the second question is iris hooks can certainly be used for supporting the capsule also. But the problem is you need to then use the international ones. The Indian ones have sometimes a sharp edge, which can rupture the capsular fornix. The ones from the international companies, they are softer silicon, so they can be used to support the capsule as well. But the main advantage of capsular hooks is they fit exactly into the fornix of the bag. Iris hooks will actually tent the capsular rhexis rather than the fornix, which is not ideal. You know, sometimes you can have a radial extension, which can totally ruin the case, because then you'll have a capsular dehiscence, which is very difficult to salvage with along with the subluxation.
Can I make a comment, Dr. Rishi?
Yes.
Yes,
Dr.
sir.
See, the one of the very valid points that you mentioned is that you should have an eye on the hook while you're doing, and the hooks sometimes tend to slip out. So whenever you after a whenever when you put in the phaco probe and immediately open the infusion, that sudden deepening of the chamber actually causes the hooks to slip out. And here the some of the newer machines with a low IOP settings, the machines which have a bit of ramp effect, so that the surges, I mean the chamber deepening is not very fast. These definitely go a long way in preventing those slippages from the rhexis margin. And another observation is that if you make a very large rhexis, then also the slipping out chances are very high. So make a small to medium rhexis. If possible, make it small, and after putting in the IOL, if you want, you can even enlarge the rhexis. Thank you.
I think that's a very good point, sir. Well taken. Should I proceed?
Yeah,
Yes,
the
Rishi,
bulbous
very
tip
nice.
of the capsular hooks are really very gentle. So that is a big difference between the iris hooks and this. Yeah.
Yes.
Yeah.
All right. So just putting in some viscoelastic again, and then at this point, I decided that it's time to put in the CTR. So I took off the hooks, and I'm introducing this capsule tension ring. I like to put it through the side port because it gives me control, better control. And basically, when I'm introducing it, I like to use a Kuglin hook on the outside and a Sinski hook in the eyelet. So that way, if in case it slips, the Kuglin hook will prevent it from going into the sulcus fornix.
Can you please stop, Dr. Rishi?
Yeah.
Yeah, I had a question. Why did you remove the capsular hooks before you put in the CTR? You could have removed it even after that, because they will hold it in place and they will give the vertical support.
I agree with you, but sometimes they can get entangled, and then it becomes very messy. And this was not like a very bad zonodialysis where I was afraid that it will totally center because of the pressure of the CTR. So it was a calculated risk.
No, because if you inflate the bag well with viscoelastic, it really doesn't.
Sure.
So I thought
yes,
maybe
certainly
that would
be
because then when you're putting in a CTR, it can cause greater zonular instability if there is no vertical support with the capsular hooks.
I agree. Sometimes the CTR itself can increase the zonodialysis. Can you stop the timer, please?
Yeah.
Dr. Rishi, how much was the zonular dehiscence?
The zonodialysis was about 5 clock-hours.
What I would like to ask you is that a small comment. If the capsular dehiscence is more, you should go, if it is less, you can go in from the area of zonular dehiscence. Yeah, I mean, when you are introducing the CTR. But when the zonular dehiscence is more, say more than 90 degree or maybe 4 clock-hours, in this case, it would have been, they say then you should go in from the area farthest away from the area of zonular dehiscence. So the way you have to insert, at times that is also very important, because if the dehiscence is less, then it can go in from the area of zonular dehiscence. But if the zonular dehiscence is more, then one should try to prefer to start from the area where the zonules are most intact.
But sometimes, when you're pushing the CTR, the bag tends to be pushed towards this direction which you're pushing the CTR. And that also can increase the dehiscence. That's what is my feeling. That's why I always try to start either within the dialysis or close to it. I don't know if the others agree.
See, when you're putting in the CTR, from wherever you are starting is the point that you would be ending. So if here is the dehiscence, then you need the complete coverage of the CTR there and the two ends on the opposite side. So if you want the two ends on the opposite side, obviously you start from the opposite side so that Wherever
Yeah,
there is
I'm not
cellular
saying that-
dehiscence, you have the complete coverage.
I'm not saying that it has to start from within it, but near it. Basically, if you start exactly opposite, you will be stressing the zonules more because you'll be pushing in the opposite direction. That's my funda, but I might be wrong. That's how I've always done
No.
They're just
Yeah.
unexplored fields. Different
Yeah.
people have different versions.
Yeah.
it.
Absolutely.
Okay, let's move ahead, Rishi. Yeah.
Yes.
Yes.
Okay. Of course, I'm using a 3-piece lens here because it was the planned lens, but since the CTR is in place, one could even have put a single-piece lens. And I'm using the soft port AO lens because it really nicely goes into the bag without need for any dialing, etc. So just with the injector. And of course, after this, when we were doing the IA, we checked for the stability of the bag and it was perfectly in place. So not a very extraordinary case with a big complication or something, but I think this is something, a common challenge, which can be encountered by many of the surgeons. And I thought this may be good for the general audience to learn about steps to tackle subluxated cataract, which is more than 1 or 2 clock hours.
Thank you very much, Rishi, for putting a very nice case. It's not an ordinary case, Rishi. You know, if we are threading CTR in capsular bag, it can complicate at any stage. So,
And
even
I
simple
also
looking
feel
case.
that, you know, these, the cases should be things that, you know, which comes to us occasionally. There's no point in showing an absolutely rare case where, you know, you do once in a lifetime. These are a lot of
Agreed.
practical things that, you know, all of us pick up a lot of practical things from. I think these are the sort of cases that should be showcased. Thank you so much, Dr. Rishi, for that nice case.
Great presentation.
Thank you. Okay, so let's move on to the next presentation, and that is from Dr. Sai J. Kumar. And sir is from is in Girdhara Institute, Cochin, a prolific cataract surgeon. So to discuss with him, I'll invite Dr. Rohit Om Prakash and Dr. Janin Patel. Sir.
Can you play my video, please?
Yeah, you need to play from your end, sir.
Oh, I thought I had sent it to you earlier, and so okay, I'll play it from my end.
Yeah.
Oh, I'm sorry. You want to take one more talk in between?
Okay, then
Yeah.
Dr. Rohit Om Prakash, sir, are you ready with your case, sir?
Yes.
Okay, so as Dr. Krishna Prasad has joined. Okay. So Rishi, you are there for 5 minutes now, so you can discuss this case. Yeah. So I'll invite next Dr. Rohit Om Prakash, sir. We all know he's an amazing and prolific cataract surgeon from Amritsar, and sir is going to showcase one case. And I'll request Dr. Rishi Swarup and Dr. Rakesh Sakya, if he's there, or
Thank
Dr. Vardhaman. Dr. Rakesh, you are there? Or Dr. Vardhaman. Yeah, Dr. Vardhaman and Dr. Rishi, please. Yes.
Hello, can you see my screen?
Yes, sir.
Yes, sir. Yes, sir.
So let me go back. So this is I would like to thank Dr. Harshul for inviting me in his great session, which always it is. And I can recall that in winter IRSI, his session was a hit and it continued for more than 2 hours.
Thank you so much, sir. And it was with champagne.
Yeah.
Wine, yes.
Absolutely. So I would be taking up a post-RK vitrectomized single-eyed apprehensive patient. Well, as you can see, there are more than 16 cuts in this patient, and he had silicone oil. So when I started, the first thing which I did was I made scleral incision. So scleral incision went 2.2 millimeter. Then the silicone oil was flushed out. And once it was flushed out, I made a side port incision, a small one and slightly posteriorly. That was the second thing which I did. Here I committed a big blunder. I should have definitely stained the anterior capsule. So for all RK patients, if they are more, it's all, I trusted the retroillumination, but I should not have. So I started, and the moment I started, I realized that I should have. But then I said, let me go ahead. So there I realized that it had extended to the periphery. So at that point of time, so I tried to introduce the other micro scissor, which I couldn't. So I introduced this 23 gauge one, created a nick and went around it from the other side. So here it was also trying to extend, but somehow I was able to retrieve it and I completed it. So that part was over. Now what to do? So I thought, let me start it and evaluate how things are. So I did the, hydrodissection away from the area on which the anterior capsular tear was. Then I started with the surgery. This is the fast motion surgery. And I would like you to see that the anterior capsule, I would show eventually, that was also, I'm trying to place everything in the central zone. I'm not having large side movements so that it doesn't put stress to the RK cuts. So you will find now I have slowed down. I'm in the center. You can see that the flap here is fluttering all the way. So, and I had done some bit of it in the supracapsular mode also. Once that was done, I tried to do the cortical removal. You will find at this point also, at some point, the flap would flutter, which would indicate that it is, pre-equatorial. I was trying to take out, which I was not able to because it was too much, the sheet was too much with the anterior lamella, too much to the periphery. I tried to do what Dr. Kamal Kapoor does of just squirting fluid to create a cleavage plane. You can see the flap, it is still, it will move. The moment, you can see it moving. So this shows that it was pre-equatorial. Then I went into the polish mode. And when I went into the polish mode, I tried to, I didn't want to leave anything behind. So on polish mode, you can see the vacuum is hardly, 85, 90. And I could take out a lot of cortex, practically whole of that, and then going to the periphery. You will find, just focus also at times on the flap, which is not everted, which is vertical, and at times it will flutter. This would mean that it is pre-equatorial. So I did all my best so that on the vacuum mode, so that I took out the whole of the cortex, showed a lot of patience. And here you would find that I'm taking it out.
I saw your presentation, very nice. Just a bit of observation that always have a better magnification in your recording.
Yeah.
And you are many times off center, so your staff has to keep telling you
Once that was practically done,
and a better magnification gives better clarity.
Can you see it flutter? It's fluttering all the way.
Many times you just see the scene, you don't see the eye because it's a deep-seated eye. The eyes looking down.
What voice is that?
This is
So
not
for a
from
better
my side.
recording, these are some essential things you can observe.
Now I'm putting
Just,
the ocular lens. So since the flap was fluttering, I continued and I put the intraocular lens in the bag. And you can see now once it was there in its place, the next thing which I did was that I checked with the trypan blue and I found it was leaking. So I just sutured it up. Thank you very much.
That is a wonderful case, beautifully managed. There were multiple problems that you could have had in this because it was post-RK and obviously a myopic deep set eye. Plus you had a capsular complication, beautifully managed. I was just wondering if that capsule was troubling you so much, could you have tried to just use a vitrectomy and just trimmed that flap a little bit after putting a cohesive viscoelastic to keep the posterior capsule away?
I didn't get it. Would you mind repeating it?
Could you have tried trimming that capsular flap with a vitrectomy cutter after putting a cohesive viscoelastic and pushing?
You mean the anterior capsular flap?
Yes, which was troubling you.
I didn't want to because I wanted to have a look at that anterior capsular flap, because that was giving me the surety that it was pre-equatorial and it was not post-equatorial. So long as it was fluttering, it gave me a definite feeling that it was pre-equatorial, and I was using safe phacoemulsification techniques in completing the phacoemulsification. Number one. Number two, what was happening was that, this was the vitrectomized eye. So the bag was, the zonules may have been weak.
Weak.
The bag was also fluttering. So when I was taking out the cortex, which was adherent, it was a very tricky situation, because I didn't want to lose the capsule at all, and I didn't want to leave the sheet there.
Correct. Because even yagging these patients is a little tricky later because they are myopic.
Yeah, absolutely.
Rohit sir, can't we, when we see that, it's difficult to see the capsular edge in spite of having the best microscope we have, can't we stain also that time, take out some OVD, try to stain it
Absolutely.
in between?
You are spot on that we should have, I should have stained. But, somehow I feel in my practice, I am, propagator of doing it under air. Just painting. Can you hear me?
Yes, yes, sir.
While painting on when
Yeah.
you use visco, you can paint on the interior capsule also. But I have somehow not been very successful in it. So I thought that I might as well continue. Yes, you're absolutely right. I could have tried that. But then, since I'm not very much into using, doing the trypan blue staining under visco, so I thought I might as well go ahead. But yes, definitely painting under the visco would have been a very good idea.
Another point, perhaps what you could have done was, once you realized that your axis was acting funny, immediately convert to a forceps, microforceps, because you don't want lateral movement in these cases because of the RK cuts as well.
Yeah.
But of course, hindsight is 20/20. At that moment, you just have to do what comes to your mind. I get that.
I think it was if I'm not wrong, it was a microforceps, because it was a hardly 2.2 millimeter incision with a scleral one. A normal capsular axis forceps would not have done. But yes, I could have created another incision, and through that micro, but that would also have been scleral for that matter. So I'm not sure whether, that would have worked at this point or not.
So, sir, it was a wonderful case. Of course, as always, great learnings from you. And I think 2 takeaway points for all our audience are going to be: one is the way you tackle the tear, basically, because to go away from that site of tear and then having a small cut and then continuing on the opposite side is something that everybody should learn. Second thing is, of course, your beautiful publication about the anterior flutter. I think this is one of the most important things that people should understand, and this gives you a lot of confidence. As you said, till the end you were looking at that anterior capsular flutter happening, so that gave you the confidence that the PC was still intact. So both takeaway points were absolutely brilliant. I would like to also ask you, what kind of lens did you choose in this case? Like, what lens was this?
It was a aspheric square-edged lens, for that matter. Nothing hi-fi about it. Why I'm saying, because of the fact that it was a toric intraocular, it was a post-RK surgery, and we had used a true K formula for that matter. It was a silicon-filled eye. Hitting zero would have not been possible. One option would have been that I should have made the patient aphakic, waited what the refractive outcome would have been, and put an intraocular lens after that. That could have been another option. But since the patient wanted to have everything done in the first go, so I thought that and the patient said even if he has some bit of refractive error, he's okay with it. So I just used a normal intraocular lens.
Yeah, so the counseling of the patient is very, very important for these cases, for especially surprises.
In these silicon-filled eyes, if you do all these things, at times, it's hitting zero. And then, if the silicone oil has to be taken out, if you go on the IOL master with the silicone oil mode, when you remove the silicone oil, I suppose the patient gets to the emetropic type, nearer to the emetropic type. But since all these patients who have a silicone oil, they are basically, they tend, I try to make them slightly myopic in all my practice, because even if, this is what, because they are more used to near vision and their distant vision is practically not always good.
I'm
Absolutely.
really sorry to interrupt, sir.
Yes, thank
Sir,
you.
sorry,
Yeah,
sorry to interrupt,
thank
sir.
you so
Sir,
much, Dr. Rohit. Yes,
just a
Mr.
second,
Raj.
sir. Yeah, sir, we are actually exceeding 7 minutes plus. Now, like this talk took 10 minutes.
Fine. We
Yeah.
we
So-
have extra 14 minutes because two speakers are not able to join. So don't worry,
Right.
we'll finish in time. Okay.
Okay.
I got your point, Mr. Raj. Thank you so
Yes,
much.
yes.
So thank you so much, Rohit sir, for this wonderful presentation. Now I'll request Dr. Sai Kumar sir. Are you ready, sir? Sai sir, you are muted, sir. Sai sir, you are muted. Sai sir, you are muted. Can you unmute yourself?
He put a message in the chat box now. Maybe sir will read that. He wouldn't realize he's muted. So put a message in the chat box.
Yeah, Sai sir is unmuted now. Okay. So I'll request Dr. Kumar, Doctor, and Dr. Janine Patel to discuss this case with Sai sir.
Am I audible now?
Yes, sir.
Yeah,
Yes,
yeah.
sir.
So
Yes,
just two cases of, capsule rip. This is the first case, the moment you touch the capsule just ripped, the typical Argentine flag sign. But luckily in this case, the cataract was actually very soft. So, just a bit of aspiration, you can easily remove the cataract. And I left the flaps there. The patient had opted for a 3-piece lens. And so, dialing in that second haptic was slightly difficult. But then after 1 or 2 maneuvers, I could easily do that. And now you can see you have those 2 flaps of the Argentinian flag there. And I make 2 small cuts and then fashion it into 2 hemi-rexes to have the IOL well placed in the back. In these situations, if you have a direct, opening, the capsule splits equally, then I think it's very safe to go ahead with phacoemulsification. Now, this is another case similar. I was able to, start the initial flap. I was planning to make a very small rexis, but then once it, went a few clock hours, and then you had the rip there. So these are situations where, especially when you're sitting temporarily, this is not a very soft cataract. This is slightly harder cataract, not very hard, but harder than the first case. So in this case, I had to, fashion those 2 hemi-rexes before I could, really start my phacoemulsification. So you have to be very careful to not to make additional rips in the capsule, and then your phacoemulsification will be even more risky, and you have a very high chance of a capsule wraparound tear of the posterior capsule also. So you can carefully fashion these 2 hemi-rexes here. And although it is sort of straight, the 2 peripheral extensions, I felt that it was not very safe, and so I tried to, rotate the capsule into the anterior chamber with a lot of viscoat protecting the endothelium. But I sort of planned for an epi-capsular phaco, but finally didn't happen. I'm practically, taking out the nucleus in the anterior chamber. This is a definite mistake that I'm making here. But I thought I'll just share this video. It was not very hard, and so with a few cuts in the center and catching hold in the periphery, I was able to remove the nucleus without much damage to the endothelium. This patient had a few DM folds the next day, but which settled down in a week's time. So the point I just want to emphasize here is that in these situations, if you're not very confident with your phaco, one option would be to convert into an SICS, so that don't make the main wound till you are very sure whether you're going to go ahead with your phaco or not. So this is the second case. And here again, a 3-piece lens is being implanted in the capsular bag. You can see those 2 ribs there, but this lens would remain in the well centered. You have to nudge the lens a few times before it really goes into the bag. So these are the 2 cases of Argentinian ribs that I thought I'll share. And this edge was slightly coming to the anterior. So I just fashioned the capsule there to make it slightly round. Thank you.
A lovely presentation.
Thank you very much, sir. Dr. Kumar and Janin. Yeah.
Sir, in this particular case, you did have a rip immediately, and you showed us the 2 ways where you did one, converting it into the Argentinian sign pre the lens and one post the lens.
Yeah.
What would be the preferred technique? Suppose it's, just before the punch. What would be your preferred technique for a CCC?
If it is a very, very soft cataract, I think you can just, you're talking about extension of the capsule, the 2 hemirexes you're talking about?
No. I was talking about, so if it is a routine Morgagnonian cataract, what normally could also be done is a typical type of rexes before it completely extends. Like to prevent your extension.
Yeah. Usually,
maybe like the use of a cohevis viscoelastic to flatten it out as much as possible.
Yeah, we use one of the highly cohesive viscoelastics. Even Helon 5 can be used, so that you flatten the capsule, and that reduces the chance for the Argentinian flag sign. The second point is that normally in such cases, I make a very small rexus in the center, and then using a bimanual, I just decompress the capsular bag, let out some liquid cortex, and some cortex is aspirated, and then you can do a second rexus, which is much more safer. This second rexus usually does not rip off because the intra-bag pressure is low.
Yeah.
But having said this, there are some cases where whatever you do, you still get, especially the young people with a very intumescent cataract. And what has to be noted is that when you make the first nick, if the fluid leaks out, in fact, you are much safer, because the leakage of the fluid actually reduces the intra-bag pressure. But in cases where you make the initial nick, there's no fluid leaking out, there's a lot of those intumescent cortex there. These are the cases which can easily go into an Argentinian rip.
So another point is, even for the nucleus management, since it's a Morgagnonian cataract, these are the nucleuses that give us enough place in the bag. So even if we take our chopper or the thing to the equatorial edge of the nuclear point and then bring it to the center, we would be able to create like equal halves of the nucleus rather than bringing it into the anterior chamber and do the phacoemulsification.
Okay, that's a very valid point. That is the mistake that I've done in this case. Here, normally when I make the first nick, and if the entire capsule rips, I feel that the capsule is very safe because it's symmetrically in both directions. But here it was not very symmetrical, so I was actually a bit scared about the rip going to the posterior capsule. And so I actually, I actually didn't even expect this sort of hardness in the cataract. I was expecting it to be slightly softer, and that's why I tried to make it advantage. Your point is well taken, Dr. Jain. Thank you.
Dr. Sai Kumar, if I'm permitted to speak, flap motility sign should have really helped in this situation.
I actually wanted to comment after your last talk, sir, because I don't know who invented this, but I have heard you speak on flap motility 2 or 3 times, and I have found it to be extremely useful. I have to be really thankful, because I think in Coimbatore, in one of the Eye Foundation meetings, I heard you, and since then, this was a video before that, and since then I've been looking at that flap. I think it's a very, very important point that one should look at. I should thank you for popularizing this particular sign.
Yeah, even I use it a lot. It's really nice.
Can I interrupt, Sai sir? It is Dr. Rohit Om Prakash's invention. His son got the best paper award at the ACRS for the same. His film got the same award at the ACRS many years back. So my comment on your videos, excellent videos, was it is, I think, your confidence as a surgeon. I mean, when you have a rip like this, you just go in and remove a soft cataract with a lot of mobility I saw in the antechamber. So our chamber was not very stable, I felt. And again, I felt was that why were you still putting a 3-piece in the bag? If you still had the bag and you're confident, then why not using single?
Yeah, this was actually the patient had opted for a 3-piece lens, and that is why suddenly I couldn't find a single-piece lens.
Correct.
There are quite a lot of people who opt for 3-piece lenses, and that is the pack. The patient had opted for that particular package. That's the only reason.
Okay. Thank you.
I could have gone ahead with a single-piece lens as well.
Yes. Next.
Okay, thank you very much, Sai sir, for
Thank
this
you.
lovely presentation. Thank you, sir. So now let's move on to the next presentation, and can you hear me?
Yeah, now we can hear you. You were
Yeah, I'm so sorry. Yeah. So thank you very much, Sai sir. And the next we have Dr. Anaga Herur. And we all know Dr. Anaga Herur is a ARC member from West Zone. And she's a prolific cataract and refractive surgeon. And I request Dr. Anagara to share her video.
Yes.
And to discuss with her, I'll request Dr. And Dr. Kumar, please stay for discussion. Anaga.
Yeah.
Dr. Anaga.
Yeah, thank you so much, Dr. Harshul, for inviting me here in this amazing session. Am I audible and is my screen visible?
Yes, yes.
Yeah, thank you so much. Actually, this is a very interesting case. So I'll be just sharing the video now. This was a patient about a cataract surgery, both post-RK and LASIK done in the same patient. So this was a 49-year-old male patient who was one-eyed. The left eye was lost due to traumatic RD a few years ago. And the right eye showed an 18-cut RK, which was done in 89, and then LASIK again done a few years later, and now complaining of blurred vision since 3 years. You can see the RK marks here and those metallic deposits that you can see in the interface. In the left, you can see the dilated position, the slit lamp examination. So you had a double challenge of both post-RK and post-LASIK. This is the OCT cornea showing the metallic deposits in the interface. This is the topography report with the central myopic ablation done and a higher spherical aberration. So a very high, a poor quality of vision also. This is the EKR holiday report showing a greater keratometric variability. So poor prognosis was given to the patient also regards the post-operative refractive surprise. IOL master with the post-LASIK mode, like on the left side, with the Barrett True K on the Technis lens showed a plus 23, with Hages-L showed plus 27. And on the right side, you can say post-RK, it showed a 21 with a post-RK in the Barrett 2K. So the challenge was which IOL power to use, a 21, 25, 27. This was the ASCRS online calculator post-myopic LASIK. We saw both post-LASIK as well as post-RK. Post-LASIK was averaging around 24.3 and post-RK was averaging around 28.8 or 21. So we decided to go ahead with 24.3, but because it was a 18-cut RK, we kept it slightly myopic 25. Patient opted for a femto. Here we made certain changes in the femto settings where we changed the segmentation rate, the anterior pulse energy increased to 9. The vertical spot spacing reduced from 35 to 30. And here you can see the capsulotomy, also the margin, the incision depth changed from 600 to 650 and the pulse energy increased from 4 to 4.5. We stained the anterior capsule with trypan glue because we knew that there could be skip areas because of the post-RK and the metallic deposits in the anterior, in the interface. With a sterile incision after peritomy, very, very light 40 and 0.8 millimeter incision. So the first thing that we did was try to raise the capsulotomy flap, which was clearly cut on one side. And just to be on the safer side, instead of just pulling it, we used a 25 gauge forceps and very gently turned it along the post capsulotomy edge, because as we know, flax creates a postage stamp perforation. So CCC or getting a perfect capsulotomy was very important in this case, because especially as the patient was one-eyed. So this was the perfect capsulotomy flap that we had. And as you can see, we are just opening it out on top of the eye. And then a very, very gentle hydrodissection. and the nucleus was made mobile. Phacoemulsification was as routine. As you can see here, we used a combination of chondroitin sulfate and sodium hyaluronate to protect the corneal endothelium also. This was a femto case, and hence when we are doing an irrigation aspiration, we remember that the femto cuts all the cortical fibers vertically, and so it can be a little difficult compared to a routine case, but once you are experienced, it becomes a very easy. So this was the irrigation aspiration. On a retroillumination, you can see the RK marks. And then we put in a one-piece aspheric intraocular lens. This was a Technis lens, no financial interest, putting it into the capsular bag. So basically what we had was a perfect surgery at the end of the case. And because it was a one-eyed patient, the patient was extremely apprehensive. Here, the most important challenge was, since the eye was subjected to both RK and LASIK in the same eye, it was very, very confusing as to which IOL power to consider, and there was hardly any literature which is explaining these such situations. But because the post LASIK was higher in dioptric power, we chose that. Fortunately, the patient did very well post-op with hardly any post-operative refractive damage at the end of the surgery. Thank you so much. I'd like to actually ask the panelists what was been their experience in such cases where you have LASIK as well as RK in the same patient.
Hi. Can I say something?
Yes.
Yes, so
Yeah,
firstly,
Dr. Kumar.
so firstly, very, very good. I mean, the calculation is the tricky part here. The surgery was well done. And I'm happy that you showed that you can do flax in a patient who's undergone RK. But the take-home message here would be that where the RK wound is, the flax energy the femto energy will not go through, and that's the area where it is not. So all these patients, like you rightly did, have to be stained to know how the anterior capsule is going to behave, even if you have done flax, because you will not have a free floating rexis like what we have normally in any other patient. So that's one important thing. And secondly, of course, as you said, the femto will cut off the cortical material, and to do a bimanual IA, you have to be a little careful. All of these patients are always apprehensive because they are one-eyed, but everything you do, and this is an old microkeratome. I don't know whether you know this. This was used by BD microkeratome, which left plastic particles in the interface. So they must have had LASIK before 1997, and that's when this used to happen. Very well known in the initial part. But excellent presentation and great result.
Regarding the IOL power calculation, I wanted to ask if anyone has had such an experience, and because you have had a varied IOL power range, right from 21 to 27. So it was really a challenge to decide which IOL power to decide.
So,
Dr. Vardhaman, yeah.
Yeah. So Dr. Anaga, of course, wonderful surgery. So regarding your question, now we have a short series of patients who had RK and then had LASIK. Even if they have not had LASIK, even post RK with number of incisions, the biometry is going to be very, very erratic. What we have seen overall is post 8 incisions, whatever formula that you want to use will not be really accurate, whether it is ASCRS, the TrueK formula, or any other formula. In fact, I had opportunity to do one study at Bascom Palmer where we had done, so where we had actually seen the accuracy of biometry with all these calculations in post RK versus post LASIK. And in post RK, only 50 to 53% people were within the plus 1.5 diopters of biometric accuracy versus post LASIK, where it was beyond 80% actually in that case. So what I do is what I'm going to also show. I think there are a lot of post RK cataracts today. One of them will be mine in now whenever I present. So we use the Maloney's method. So that means that what we do, we leave the patient aphakic and we see the patient next day. We do the retinoscopy the next day. You can also do the same intraoperatively, but doing the next day gives you more physiological reading. That's why we do the next day. Then we calculate, for example, it's a 12 diopter reading on retinoscopy. You have to multiply it by 1.7, and whatever reading comes to that has been very, very accurate. So I think now we in Pune, we have a series of, I think, almost 65 patients where we have done post RK calculations with this method versus the ASCRS and also on the IOL Master 700. And we have seen this method to be doing much accurately in majority of our patients compared to any other method. So that's what we are doing currently. Thank you.
Right. Thank you very much, Dr. Anaga, for your wonderful presentation. And I think let's move on to Dr. Gaurav, as he has his own course running simultaneously. So he has to go for that course. So I'll request Dr. Gaurav Luthra to present his case. And I'll request Dr. Anaga and Dr. Kumar to please stay for discussion with Dr. Gaurav.
Thank you, Harshul. Thank you so much. I'm privileged to be in your course, and I can see that you're on the road and still conducting your course really well. And
this is the advantage of technology, you know.
I know, and advantage of virtual meetings. You can be anywhere and still be attending and conducting courses, right? So So this is a pediatric cataract, and actually I'll be showing both the eyes of this patient. So because we tackled them differently. Now this was an intumescent cataract. So after we started the rexus, we realized that it might run out. We were using, of course, all the precautions with viscoat and everything, but we did a small aspiration to debulk that cortex. And then, you can always complete the rexus. You can start small, and you can see that I'm using this instrument to stabilize the globe, which does not allow viscoelastic to come out. So if you'll notice this here, this small device is, I think, named after Dr. Haldipurkar sir. It kind of stabilizes the globe, but it also occludes the wound. And that way the viscoelastic will not come out during the rexus steps. And then, of course, once the rexus was complete, it's a breeze to remove the cortex. And
Dr. Gaurav, can you mute this video, because I think that music is coming
sound,
from.
yeah. Yes.
Perfect. Yeah.
Yes. So I lifted up after using a viscoelastic. I've lifted up that small flap, and then I'm injecting into the burger space to lift up the capsule. Now I'll try to hold it with my rexus forceps, and I'll try to design a rexus. The aim of the rexus is that it should be a little smaller than your main rexus. Even the main rexus, usually I make a little smaller than the 5 mm which the Virion shows, because at the end of surgery, it typically expands a little bit. So I would probably aim for a 4.5, and for this posterior rexus, a 3.5 or something would be ideal for me. But you can see here that I'm into a situation now because it's beginning to run out. 90% of the times, these posterior rexus are much easier than the anterior rexus because they never run out. So this was a one-off case where it was insisting on going away. I'm using all the maneuvers that have been taught, including the maneuver to pull it in. You can see that I'm pulling it in, and yet, I'm getting a rexus size which is bigger than my anterior rexus. So I'm in a situation now that I have a rexus which is bigger in the posterior capsule than on the anterior capsule, and I am aiming to put my lens into the bag and do an optic capture into the posterior rexus, a double capture of the anterior, of the posterior rexus and the IOL in the bag. So of course, now I'll go and do a little bit of anterior vitrectomy, and I inject a 3-piece lens which I'm aiming to put into the bag. And here, of course, it is better to open the lens in the anterior chamber, not to aim for getting it into the bag straight. And now I'm going to do a haptics into the sulcus and a double capture of the anterior and posterior capsule, because that would lock my lens into place. It would also prevent PCO. So I've captured on one side, I've captured on the other side. Things seem to be going really well. And just see what happens. Now, as soon as the other capture was done, because the posterior rexus was much bigger, the haptic has dislocated from the sulcus and gone through the rexus along with the optic and gone through the posterior capsule. And luckily my rexus is not broken, but so this lens will not hold into the captured optic of the posterior capsule. I'd actually tried 2-3 times, and every time the same thing was happening. So I had to decide not to do that. And I had to now leave the lens in the sulcus without capturing it. And so this was a bit of a lesson learned. And of course, it was an unintended bigger posterior capsular rexus, but the lesson was, so for the second eye of this patient, we decided to change things a little bit. And here it was again an intumescent done about another month later. And you can see that again, a very intumescent cataract, aspirating it. Wait a minute, is it the same video showing? It was the same video showing. I'm so sorry. Let me just mute this, please. So second eye of the same patient, and I'm going to, let me take you forward because there's nothing special in the anterior rexus. and the anterior rexus was completed. You can see it's a little smaller than what my virion was showing me. So it's a little smaller than the 5 millimeters that I would normally aim for. Cortex is easy to remove. And now we have to do a posterior rexus, which I'm not sure how I'm going to do. So what I decide is to inject the lens first. So I've injected my lens into the bag. And this time I'm worried because if I do a posterior rexus, then it's going to behave the same way as the first eye, which is very unusual mostly. I'm now using a cutter. So after putting the lens in the bag, I'm going to make a small rexus with the cutter, posterior rexus. And it is again quite good to do because you can also do a vitrectomy along with that. And it's a very controlled way of doing it. So I've managed to get a small rexus. Now I'm going to suture my wounds and make sure that everything is stable inside. And then I will come back and enlarge that posterior rexus a little bit with the cutter as well. So now I've closed my main wound, and then I'm going to go back behind the lens and fashion a slightly bigger rexus, which is about 3.5 to 4 millimeters, as I would have liked to. Only thing is I cannot capture my lens through this small posterior rexus because it'll probably break. It's not a continuous rexus. But so this is another way of doing, in pediatric cataracts where you are probably scared of doing a posterior rexus because it might run away or for other reasons. This is another good way of doing the thing. And now I'm going to seal the wounds. You can see that it's a little difficult to seal them. So I'm going to suture the side port as well. If in doubt, you can suture them. I also like to do supraincisional tunnels, but for this child was about a little less than 1 year old. It's not possible to do that, but the strip and glue Seedles test is very good to check for the integrity of the wounds and be sure that you have the right thing. Two different ways of tackling the same thing.
Yeah.
The first one, has anybody else encountered this situation where you try to do a posterior optic capture and you get a rexus? I've never actually had a rexus in the posterior capsule go bigger than what I intended because the control is usually much better. But for this particular child, whatever I would do would not allow me to retain the size of the rexus inside as I would have liked to. So any pearls where I've made a mistake or anything?
Dr. Kumar?
No, I think the presentation was fantastic, Gaurav. Only thing, you have a femto. I guess you've done this case before you got the femto, because I think all this would have been much easier with the femto. Now they also do a PCCC with a femto.
Anaga?
1 year old child. No?
NST, no, they do. It's quite done. You have to be careful, and that is possible, but.
Okay.
With Kumar, anything is possible.
Always thought pediatric. I've never tried femto in children under sedation.
No, in fact, Anaga, he's right that you can do pediatric, but the problem is always that with the anesthesia and everything, and the 1 year old child is going to be very, very tough. And then the posterior capsule, to show videos, it's nice to show videos with posterior capsulotomy with the femto. Dr. Grewal has shown excellent videos and some other people have shown. I think Kumar has also done one. I'm not sure. But frankly, in real life situation, if you want to do it routinely, I don't know. But so one pearl that I do know is that you should never overinflate the bag when you're going to do a posterior rexus. If you tend to overinflate it with viscoelastic, then there can be a problem. So you always just put enough. And also then that goes too deep. If it goes too posterior, then your instruments will find it tougher to go and do it. So I typically don't overinflate it. But here, I did everything right as what I thought I was supposed to do. And yet, I managed to have that rexus not wanting to stay where it was. Even with the Brian Little's maneuver, I was trying the Brian Little's maneuver several times to bring it in. It would not come in at all. So anyway.
Maybe how the capsule actually responds in an adult when you're changing it from converting from a posterior capsule or PCR to a PCC versus when you're doing it in a child is totally different. So I think here in this case, you cannot afford to have something like this because it becomes a very, very difficult situation, especially in a child. So I think your second you're learning, that when you're using the vitrector is playing safe, even though you may not be able to do a double capture, still you're playing safe. And I think that's a more.
It looked much more controlled and much easier. Yes, Harshul.
Thank you.
Excellent.
Yeah, no.
We are running short of time, so I think yes.
Hall coordinator is again telling me that.
Please go ahead. Yeah.
So thank you so much, Dr. Gaurav, for that wonderful presentation. Now I'll request Dr. Kumar to please show his case, and I'll request Dr. Gaurav to please stay back for 5 minutes for discussion, and Dr. Rakesh also. Yeah. Yes.
I've got 2 cases, so I'll go fast.
Yes.
Thanks, Harshul, for including me in this course. It's always fantastic. I learn a lot. So the topic is when the going gets tough. Some of you might have seen this. So this patient operated by me 20 years back, had no record of surgery, no idea what lens was put. On B scan, we knew that there is a lens inside. So we don't know the design of the lens. We don't know anything. So in such a scenario, what will you really plan? We know that there is a lens inside, traumatic dislocation, and the lens is completely gone inside. So now I realize that the lens is in the mid-vitreous or little above. We put a port, and then we make sure that we prepare to do a glued IOL at a later date. So I was intending to explant this IOL, whatever it is, and then prepare for a glued. So before we make the main port, I decided to make the flaps and then started the vitrectomy, and the lens came up. You realize that when the lens has come up, you realize this design. Now this is operated 20 years back. Those days, the optics used to be 6.5 and they had dialing holes in them and the modified J design of the haptic. So these are large haptics. They are big haptics. They're not small haptics. So you can see that I've held on to the lens and I'm now putting an iris repositor below that, supporting the lens and bringing it in the anterior chamber. So now I've got the lens. And now there are 2 ways of handling this is what to do. So now this is very, very important that you can see that this formation of the haptic here and this formation of the haptic here. So I thought, why not glue the same IOL back? So if I can't glue it in this direction because it's upside down, so I decided to flip this IOL in the anterior chamber itself. So you need a Sinskey hook and an iris repositor, and I flipped it. So now my direction, if I want to glue this, is in the right direction. So I got the lens into the anterior chamber, flipped it, and I had already prepared my side ports to make sure that we can glue this IOL. And now I'm going ahead and engaging it. So now I'm going ahead and doing a handshake technique, what Amar has taught all of us. And it's a fantastic technique. And this, as I said, is a large modified J haptic. It's not very easy because a lot of areas. So you can see amount of haptic that has really come out, because they are large haptics compared to the old. And now this is the other side. So I've got one side out and the other side in, and now getting that other side out and then tucking it like what we normally tuck. So important take home message here is you should be prepared for everything. You don't know what lens it is. And if it is lucky like this, you got a, J 3-piece IOL. So why not, glue the same lens? And there is no question of biometry, no question of what is IOL, because the patient was very happy for 20 years, had a trauma, dislocated the IOL, and that patient did extremely well post-op. So just gluing the same lens back, putting air and making sure everything is well centered, constrict the pupil, and it's all done. So then we continue. So now another case, 2 cases, as I said. Now this is, you can see that it's a 3-piece IOL, decentered, okay? Now this is all the pupil dilates. The pupil doesn't dilate more than this. So then what to do? So I decided to go ahead and put 4 hooks to see what are we really dealing with. So here you can't use a Mulligan ring. You have to use hooks because that will take you till the equator as to know what's happening. And once I did this, I decided to center this IOL and see what are we dealing with, right? So this is again an IOL. So I did a marking on the cornea. Once I did the marking on the cornea, I decided that I will make a little puncture in the whole capsular bag, which is behind, where the anterior and posterior capsule had actually got stuck. And then decided to do a small puncture in the anterior, in that back complex, which is posterior, with the vitrectomy. So once I got that, I decided that why not save the same IOL, which had actually decentered down, to prevent it from decentering. I made this little puncture. So you can see that I made a little puncture with the vitrectomy in that capsular back complex, which is posterior. And then I decided that why not entrap this optic. So you can see that I'm putting the optic below the anterior posterior margin. The inferior one has gone below, and now I'm doing the superior one. It will go also behind the complex. Sometimes this complex may be a little too small, the puncture that I made. So I may go ahead and then again do a little bit of more vitrectomy and then make that complex little larger so that the opening is little larger in that complex so that we can capture the optic very well behind. So here you can see that I've enlarged the opening in the complex, and now I'm going ahead and then capturing the optic. So here I put the optic behind. The inferior optic has gone behind the complex. The superior optic will now go behind the complex. So here what I've done is recaptured the 3-piece IOL into the back complex, which was actually adherent. And now this, you can see the entrapment of the optic. You can see the stretch and the eye opening that you see in the middle. Remove the haptics, and this is perfectly centered well. So this lens will now never ever decenter. Although primarily the lens had decentered and gone down. So this is, I thought I'll show 2 cases which beautifully save the same. So this is just the ending. So the body always, believes in what it wants to. If the mind doesn't really know about it, I think this is what can help. Thank you, and thank you, Harshul, for having.
Thank you very much, Dr. Kumar, for wonderful presentation. I think we have 1 minute for discussion. So any panelist have any question to Dr. Kumar? Dr. Sai?
What would be the size of the the opening that you try to make, Dr. Kumar? I mean,
if this optic again was about a 6.5, which had dialing holes in it. These are those old optics you might have seen.
The old ones, yeah.
So at least I think you need a 4.25, 4.5 opening, and that entrapped it very well. And you can see that J line because the 2 haptics, and that direction of the lens was correct because it was put in the right direction. So there's no need to flip that or anything. And this lens will now never ever decenter.
And have you had any case where when you try to capture the posterior capsule had got torn, and any experience?
Really, these are back complexes, but primarily I think the lens was not put in the bag, and
okay,
so it might have been and these are back complexes where the anterior posterior capsule are stuck and they become very fibrous. So they are very
fibrous.
Yeah, they're very strong.
Usually don't rip off. Yeah, very true.
Correct.
Thank you.
Thank you very much, Dr. Kumar. Let's move on to next presentation. That is from Dr. Rakesh Sakya. It's from Chitrakoot. We know he's a wonderful surgeon. We have seen his live surgery many times. And Dr. Rakesh, I'll request you to give your presentation. Yes.
Thank you.
And I'll request Dr. Sai and Dr. Janin, everybody to please stay back for his for discussion with him. Yes, Dr. Rakesh.
My video is running?
Yes.
So this is the case of subluxury cataract more than 6 clock hour, and this is the angle recession glaucoma. This is the history of the blunt trauma. And vision was 2/60 and IOP was 26, and fundus was normal, and B scan was also normal. So otherwise the immature cataract. So I put the visco in the antechamber. I decided to do the phacoemulsification in this case, and without oil with sioneering. And after nicking the entry capsule, and I actually complete the rexus with the help of the trata forceps, slightly keep the rexus slightly decentered toward the intact jonule. And then after during the height of the BTS was prolapse, so I cut it properly, and then I make a slightly scleral tunnel for the suturing and 3 port for the capsular hook. I have to stabilize the lens very well. And then after that, I did the hydro again to loosen to actually free the nucleus. And then nucleus was slightly hard. So I make a deep trench and then do the stop and chop technique. And then one piece I remove from the bag and then complete the phacoemulsification. So during the IA, actually the bag in actually the BTS and again prolapse, and the bag is shifted nasally. And then I just deposit with the iris deposit and cut the BTS again, and put the visco and inflate the bag and try to put the sionerings. And then initially sioneering in the first attempt is go into the angle, and then I remove it, and then I try to put in the leading haptic in the bag. But during this condition, the CTR gone in the BTS cavity. So I again remove it and then again try it, and I tried about 3-4 times. And then I remove, and then I can remove, post again, and then again the capsule was all again shifted nasally. So I try to remove with sioneering, but then I decided to put the another capsular tensor ring, and then bag was inflated. But during the rotation of the CTR, the Sioni ring is also rotated. But with the help of the two Shinsky hooks, I tried to remove it again and again and again and again. And then after that, we from the Shinsky hook, I tried to remove it from this port and the main port, and then I hold with the Shinsky hook and then hold it and then try to remove it, and then leading after and then tried it again and then do the vitrectomy again, and again is actually I try to put. And this time the CTR Sioni ring is gone in the back side, but the picture abhi baki hai. So when I just suturing the eyelid, the suture was broken. So this is why very shocking news for me, shocking things for me. And then remove this suture, and then I try to what we do. So I just thinking about the 4 minutes, and then I try to take another suture, passes through this eyelid of the Sioni ring, and then I keep this the 26 half needle, and then go and then keep this needle in the side port, and then again pass through the scleral pocket, and both needle passes through the scleral pocket. So after that, we suture it properly, and then this time my tension was released and bag was inflated, implanted in this case. But during the IL implantation, many times I rotated the IL, but they are not go to back. But finally it gone into the back, and then but near the Sioni ring, near the eyelid of the Sioni ring, the IL was slightly elevated. It may be due to the eyelid, or maybe after the completion the vision was 618 and the final post of vision was very good. And then so when the condition become difficult, so I will try to manage this case accordingly. Thank you, sir.
Very nice, Dr. Rakesh. You really, it was, yeah, sometimes it happens that, it's Murphy's laws. when it has to go wrong, it will, just keep on.
After seeing this, you just really feel like saying, no, happy ending, all is well, all is well. Like when you said,
the end result is very good. So I was happy, but I tried
end result is very
times. I think about the 2 hour this case. Actually,
yeah.
But the amount of adrenaline you must have pumped during the case is phenomenal.
So during the surgery, I connected my body and soul together, and then I did this case. So by this reason, when the situation becomes difficult, so you can step up and handle it according to the situation. So there are the many situations coming according to, because if you are an efficient surgeon, you can do the subluxation catheter very easily. But sometimes you are in trouble. You faced many conditions. Thank you.
Thank you very much, Dr. Rakesh. I think let's move on to next case, and that is by Dr. Janin Patel. And I'll request Dr. Rohit and Dr. Sai Kumar sir and Dr. Vardhan to please stay for discussion with Dr. Janin. Yeah, Dr. Janin.
Yeah. I'll just, is this screen shared?
Yes.
Can we see the video?
Yes. Need to play that.
So this is a routine case. Yeah. It's playing. Is it not playing? One second.
Yeah, it's playing.
Is the video playing?
Yes.
Okay. So this is a routine cataract, and I had no plans for anything because on slit lamp examination and pre-op, everything looked routine. So I was just going in for a routine grade 3 cataract, a brown cataract. And while doing this surgery, all I was thinking of is it's just make sure that I use less energy, less power and all that jazz to keep my things the normal thing that we use. And suddenly when I was doing the phaco, I realized I had an area of zonular dehiscence. So I just want to re-show that thing, and I got this, and I realized that there is something that's gone wrong. So let's review what went wrong, which was actually missed, so that we can take the case further. There was a pre-existing zonular dehiscence and a zonular weakness that was present in almost all the quadrants. So this quadrant also had it. And even when I was rotating the nucleus, I saw that this was obviously seen later on, but there was a zone dial here. However, we did put in tricot to see if vitreous was coming. There was no vitreous. And I continued to now support the bag with the capsular hook. So I realized I had an intra-op zonular dialysis, but I supported the bag with the capsular hooks and went ahead with the phacoemulsification. Now lowering all my pre-existing parameters, because now I did not want the bag to collapse. I did not want the vitreous to come in. I also wanted this cataract to come out efficiently and do the case routinely. Just as when I was doing the case, I realized that the bag is also beginning to now come into the phaco probe, and maybe getting the nucleus out was getting difficult. So I decided to go ahead and put in a CTR so that I will have an equatorial distribution of the tension. And obviously we know that the lens itself acts like a CTR. So it did play its role till it could play. And post that, I put in a CTR at a stage. And we all do believe that the CTR should go in as early as it should and as late as it can. But I think this was the best time for me to put in the CTR. I continued with the phacoemulsification, and the last piece of the cataract is now removed. And I'm actually breathing and I'm thinking, chalo, achhe se ho gaya, everything's fine. What I did not diagnose preoperatively is getting managed well. So I've continued with the IA and the irrigation aspiration, again, all on low parameters, just to make sure that the vitreous is not going to come in, because that was my only thing that I was now fearing, that I don't want vitreous to get hydrated and come in. So this is when I finish my IA, and I decide to go in and put a 3-piece IOL. And just when I am doing the 3-piece IOL, I'm directing the haptic into the bag. So the haptic is getting directed into the bag. I'm making sure that my lens is going into the bag, and I realize that my trailing haptic gets stuck into the plunger. But what happens is, because it's stuck, it also loses its shape a little bit. However, I say it's not too bad. Let me just go in and dial it in position, and I go in and dial the lens in the bag. Once the lens gets dialed in the bag, I decide to do my viscoelastic wash. But I see that there is a little bit of cortex that has happened to come behind the lens. So I'm just now thinking that the cortex behind the lens needs to be cleaned up. And I plan to position the lens, do an irrigation aspiration for the cortex under the lens to be clean. I've started feeling that the haptic is possibly not gone into the bag. Am I right in my thinking? Because I'm not feeling the lens has stabilized itself in its position. However, I'm now in a dilemma of what to do. So I go in with my irrigation aspiration and first decide to get my visco out and see what is the stability of the lens. And I realized that yes, the haptic has not gone into the bag. And at this stage, I am trying to see that my lens is also kind of getting a little subluxated. So I'm thinking this is good enough, and better can be the evil of good. Do I really want to do it? And I say, okay, let me just give it the last try of getting the subcortical, the sublenticular cortex out. Just when I am trying to get the sublenticular cortex out, I also realize that the bag is now dislocated below the lens. That means the zonular dialysis has increased a little bit. Now the fear factor becomes that I have the CTR in place. Do I leave this alone and just let it be as good as it is? Or should I really now plan an IOL exchange? Or what should be my next step? So this is now my catch 2020 situation. I decide to go in and give the patient a stable lens. At least if I cannot give it in the bag, I thought I'll go ahead and do a secondary IOL fixation. So I now come ahead and remove the lens, do a proper vitrectomy, making sure that all the vitreous is cleared from the anterior segment of the anterior chamber of the eye. Now, once I'm doing this, I'm also planning how am I going to do my fixation. So I decide to, because it's a wet field now, I use my Vicryl to give me the 80-180, and I take the CTR and I'm doing a proper vitrectomy around the CTR. Now I put my trocar and the cannula in the area of the 180 and the 0. So that place can now be used for my Yamanes to externalize the haptics as well. The CTR is now removed from the eye. And I take another 3-piece IOL And with the help of the glued forceps, I externalize one haptic. And this haptic is then just tucked into the scleral pocket. And then I externalize the other haptic. So we don't make a flap here. We don't use a glue. It's just that the externalization is done through the same port of the 0180. And then the sutures are taken and the case is ended. Thank you.
Okay. Dr. Sai, Dr. Rakesh.
Very
Quick
well
questions
managed,
here.
Dr. Henin. Very well managed.
Thank you, sir.
Lot of grit and common sense you've used. I think it was a good decision to remove the lens, because that lens would have, decentered or even dislocated later on. So it was an excellent decision. On the whole, very good.
I think it was a brave surgery, excellent ending. Hats off to you for doing it. Yeah, with the haptic slightly, you could have, twisted it at the incision itself so that it would have gone, in the right direction.
Yeah, I didn't know what to do. The last thing I realized, it will go and sit in the sulcus in the area of the subluxation.
You were in fact lucky that you could get hold of the CTR. Sometimes it just gets lost.
I have never seen anybody get hold of it.
True. So thank you very much, Dr. Janin. Let's move on to Dr. Vardhaman's presentation. We all know he's a prolific cataract and refractive surgeon at Asian Eye Hospital, Pune, a great friend and great surgeon. Dr. Vardhaman, all yours. I think this is the last presentation we have. Yes, Mr. Raj. Yes, the best for the last.
Yes, thank you, Harshul Bhai. I think it is always a pleasure and a great learning to be part of your course as always. And thank you for the kind invite. So I'll just share my presentation. Is it visible?
Yes, yeah.
My PowerPoint is visible?
Yeah, we can see that. Please go ahead.
Right. So thank you. So we already have had 2 cases of post-RK cataract. So this is a young female. Again, she was relatively younger, but she had undergone RK when she was very, very young. Like she was probably hardly 9 or 10-year-old when she had undergone RK surgery with almost 18 to 20 cuts in the eye. She had already lost of her left eye to trauma because, as you know, after RK, the incisions can give up very, very easily. And now she came up with this kind of situation. As you see, she already had almost grade 3 to grade 4 cataract. The RK incisions were very long, right from almost central cornea till going towards the limbus, cutting the limbus actually. So that had made the cornea extremely unstable. The cataract was dense, and when you look at the tomography, you can actually see that the cornea has become so flat that the average keratometry has dropped to almost 28 diopters. So it's extremely, extremely flat cornea, and you can see that it has caused so much of positive spherical aberrations because of the RK procedure. When it comes to the calculations, you can clearly see here if we want to use the IOL master, it was showing us almost 13.5 diopters. When we went to the RK calculations by ASCRS, in this case, you can see that the calculations actually were showing close to 15.5 diopters. So there was this kind of difference that we were seeing. And now let's go to the surgery itself. As you know, in RK, it's very crucial that you don't intersect into the incisions. So here we have, we have created 2 side ports between because you can have surprises anytime. Plan because these are very big bags. Actually, these are big bags, and one thing I wanted to show you was on the IOL master also. You can see that the anterior chamber depth was almost 4.54 millimeters. So it was a very, very deep chamber, that 1.5 millimeters. So it was a very, very long eye. Again, as we have discussed, you need to have the scleral incision. Am I online again, Harshul bhai?
Yes,
You
yes.
lost your video.
Yeah, 1 second. So because I think my internet just kind of.
Yeah, please share again. Yeah.
So basically, I think probably we had already seen that I had created site ports and I was trying to do my Rexes.
Capsular access, yes.
Rexes is always under your stain, basically because you need to have a good and big Rexes. And
Vardhan, we can't see your video. Please share
no?
your screen. No.
Okay, 1 second.
There again.
I'll share it again.
Yeah, now we can see. Play the video. Yeah.
Okay, sorry about that. Thank you again. So basically now, as we have discussed, your side ports have to go between the incisions. It is very crucial. You always stain the capsule to perform your Rexes. Your Rexes has to be big enough because these are very big bags and the cataracts are generally very, very big as well. Typically, this post-RK cataracts we have seen are more on brownish side. They also to be done always as the main port. When I did the hydro, you can see that actually the cataract kind of popped up from the capsular Rexes because it was a bigger Rexes, but I didn't want to actually put it back because sometimes such capsules can also have instability. So I did my phaco under the viscoat. This was a viscoelastic at the pupillary plane. So once this was done, you have to be very gentle and do what is called as a slow motion phacoemulsification, and make sure that you keep feeling and refilling with the viscoelastic as well as with the viscoat all the time. Okay, so once you have done that, again you go ahead and then you heat up the rest of the cataract. Once that is done, basically then you go ahead and you perform your irrigation aspiration. You have to be very, very gentle because the PC can be very friable in such cases. All right, so once your irrigation aspiration is performed, actually, as I discussed in the past, what we do is that we actually close the incisions. We see the patient on the next day. If the incisions are less than 8, then what we perform is intraoperative retinoscopy. But when the incisions are more than 8, what we do is on the first day post-op, we do a retinoscopy for this patient. So when we did the retinoscopy for this patient, it was 12.5. So by Balloni's method, it came to almost 21.5 diopters of IOL. So if you see in the beginning, I had shown you on IL master, it came to 13 diopters of IL power. On the ASCRS calculation, it was 15.5 diopters of IL power. And now we were getting 21.5 diopters of IL power. And ultimately, that is what we went with the next day. As you can see now, I'm using intracameral adrenaline to expand the pupil, open up the same one single side port and the main port, and then I'm implanting the Technis lens. It is better to prefer a negative spheric lenses in these cases because the arc incisions are going to induce a lot of positive spherical aberrations on the cornea. So you should be able to negate it somehow if it is possible. And once this is done, then you actually close the incisions. This is the first day post-op, and you can see that we actually got a very, very accurate biometry in this case. For example, if you would have stuck with even ASCRS formula, which showed 15 diopters of IL power, we would have been hyperopic by almost 5 or 6 diopters of surprise. So I think this Maloney's method is what we have seen overall really helps us a lot, especially if your incisions are more than 8. And now we have a decent size of series that we are trying to compile together and publish together with this. Thank you very much. And I would like to take any comments and also questions.
Thank you very much, Dr. Vardhan. That was really very beautiful presentation. And any questions, Dr. Kumar, Dr. Sai, any panelists?
This is actually an eye-opener because the ACRS is also going wrong, which I have faced a bit, but I've not faced it to the extent of 5 diopters of hyperopia. So this
in this case,
Vardhan, with your Maloney's, are you all always as close to the normal as possible with the Maloney's? Like, because it's huge, 13.5, 15.5, 21. So would you say this is the best method to go by?
Absolutely. Yes, of course. So whenever I have very, very erratic corneas, I always go by this method. And importantly, like whenever your incisions are more than 8, and in this case, there were almost 20 incisions, and incisions were starting from almost central cornea to go and cutting the limbus. So these are the corneas which are going to be extremely flat and very erratic. So if
Sorry to interrupt,
Yes,
sir, but
all
the
right.
time
Yes.
is up. I'm
Yeah,
really
okay.
sorry.
Yes.
Okay. Thank you,
We are also
everybody.
done. Yeah.
A lovely session.
Thank you so much, Harshul.
Thank you, Harshul bhai.
Thank
Thank
you,
you,
everybody,
Thank you, everybody.
for your
Great to see
wonderful
everyone.
participation. Yeah. Thanks a
Thank
lot.
you so much, everyone, for such an
Thank you.
Thank you so
informative
much.
Thank you.
session. By this, we conclude the session.